Morning, guys. Happy Monday. First of all, I just want to say sorry I wasn't not available on the discussion boards this past week. I was at CSM and then dealing with a death in the family on my wife's side. So getting back into the swing of things this week. So I just want to do a quick review of what we talked about last week in relation to cervicogenic headaches and temporomandibular joint disorders. They kind of fit together. And certainly in my own career, I didn't have a lot of training in temporomandibular joint disorders. It really wasn't something that was heavily emphasized in my entry-level education or even in fellowship training. But if you look at the literature, there's actually a decent connection between the neck and the TMJ. And in teaching this content to our entry level and in residency, I found that you can really simplify it. It's an area similar to maybe like the foot and ankle or maybe the SI joint that the people that are experts in it tend to make it very complex, very biomechanically related. But if you really dive into the literature, it's not necessary to do that in order to effectively assess and treat someone. So we'll talk about that more. Over the weekend, we'll practice a basic examination screening process, some techniques that are effective that can be easily picked up and implemented into your practice. Cervicogenic headache is an area that's been studied pretty well in PT, showing that manual therapy and exercise can be effective. The Dunning article was interesting. We'll talk more about that if you all want. Kind of a biased article from that group that really, the thing that they teach is thrust manipulation. So that's what they sort of, in my mind, set out to prove in that study, that thrust is better than MOB. And if you look kind of the way that those two, the treatment group and the comparison group, I didn't think it was necessarily a fair match, and there's some bias in it. That being said, I think manipulation can be very effective for folks with cervicogenic headache as long as you're appropriately screening them and that they're on board with it. But certainly I think there's better ways to do mobilization if you're more comfortable or your patient's more comfortable with that. And still be just as effective. So we'll practice that and talk about that more over the weekend. I think the hardest thing with headache is really the screening process. It can seem very straightforward when you read about it, when you have that patient there in front of you, particularly if they're presenting with a little bit of a mixed bag with their headache, like some cervical stuff, some features of migraine, or maybe tension, cervical. It gets a little bit tricky with your differential. And what you might find is you're able to help the patient with kind of their musculoskeletal components and impairments, but they have some other factors, whether it's migraine, tension, or other things, allergies. There's all kinds of things that can cause headaches that they might benefit from pharmacological medical management. And sort of sifting through that can be a little bit tricky. So don't feel like, oh, it's going to be a very straightforward process. Sometimes it is, but many times it's kind of a multifactorial presentation, like a lot of our musculoskeletal disorders are. So keep up the good work, guys. I'm going to be sending out some info for our weekend that's coming up this weekend. I'm really excited to do that. Hang out with you guys for a bit, discuss, practice, talk. We'll have a really good time. This week we're going to be talking about whiplash, which is an interesting topic, a little bit depressing when you read about it and the effectiveness of PT for it, although there has been some newer stuff out there. One of the articles we're going to read looks really promising. So stay tuned to that, and I look forward to discussing that with you this week.